Gurka, and I'm the Director of Living Learning Programs here at the university. These capstone projects mark the completion of our inaugural year of the Sophomore Scholars and Residence Program. SSIR is the university's quality enhancement plan for our SAC's reaffirmation of accreditation. While living learning at Richmond can be traced back 2 decades, Sophomore Scholars serves to expand on the past models by incorporating effective assessment, creating a 2-semester experience with a capstone project, and an academic emphasis, all while addressing the social and developmental issues that sophomore students face at the university. The SSIR communities take the traditional coursework, reading, research in class, and add to it experiential learning by going into the community, across the country and the world, to connect all the pieces together to create these capstone projects. To begin with this evening, I'd like to introduce to you Dr. Rick Mays, the faculty director for the Sophomore Scholars and Residence Program and the faculty member for our Global Health, Infectious Disease, and Human Rights community. Dr. Mays is an associate professor in the University of Richmond's Department of Political Science and a faculty research fellow at the University of California, Berkeley. He received his PhD from the University of Virginia in 2000 and a National Institute of Mental Health postdoctoral traineeship at UC Berkeley School of Public Health from 2000 to 2002. In the early 1990s, he worked on Medicaid policy in the White House for George Bush Sr., and thereafter on health insurance and Medicare policy at AARP during the Clinton administration. He is also a graduate of the University of Richmond. Ladies and gentlemen, please help me introduce Dr. Rick Mays.
Thank you very much, Andy. I want to reserve the bulk of my thanks for a lot of people who support the program to the very end of the evening, because we have so many great presentations. I want to get to it as quickly as possible. I want to take just a moment for those of you in the audience who are here thinking, what exactly is the Sophomore Scholars Program? And I want to just say in a nutshell, what we're trying to do with this program is we're trying to bridge students' social life and their academic life. Okay. That's actually a lot harder to actually do than it is to say, because these 2 parts of most students' careers and their experiences usually compete with one another. So what we're trying to do is make their social life and their academic life integrated and allow them to build friendships while focusing on academics and pushing sophomores to do even more academically than they normally do. The key to it all is that they take a very intense graduate level course and they live together in a residence hall. So they're taking the courses, they're living together, and they're also traveling together. And through these experiences, they form great friendships around academics and around supporting one another. I wanted to do one sort of soapbox moment on teaching and say another part of the program is it requires professors, and I think this is a good thing, to reassess why we do what we do. I give tests and exams and papers largely because that's what my professors made me do. But this program allows us to step back and say, is that the best way to make students learn? Are there better ways to make them learn? And are there ways that we're not doing because we're doing the standard coursework? And in my opinion, I think this plays out in the Sophomore Scholars Program. Tests and exams and papers and assignments are just a means to an end and not an end in themselves. So they're very malleable. You can change them to other assignments, other activities that perhaps students might like a lot more and be less stressful. And we think we've done that this year. In addition, the kind of people that became heroes in our program, Paul Farmer in the top left, Muhammad Yunus in the center, Greg Mortensen in the right, Al Sommer, an ophthalmologist at Hopkins in the bottom left, and Nichai Viravidya in the bottom right are just a number of some of the heroes that emerged from all of our coursework. And one thing they have in common is they all appreciate research. They all leverage research, and they believe very much in science and applying the things that they find in the research. But what makes them unique and what makes them stand out and why you don't really see professors up there is that these people are in the field. They're actually out they're practitioners trying to improve a variety of economic and health indicators. And for that reason, I believe that the students who take this class also get some insights on how they might want to live their life while they're here at U of R and after. Because just learning more knowledge for the sake of knowledge isn't very inspiring. But if you can see people who are using knowledge to help other people and make the world a better place, then your studies can be a lot more interesting. This is the first slide we begin with, way back in August, which now seems like an eternity ago. This is the kind of slide a professor likes. We have an x-axis on the bottom of wealth in each country, GDP per capita. And on the y-axis, we have infant mortality. These are all sort of technical terms. We get used to them a lot in public health. And you can see, just by looking at this very tight correlation, that richer countries, it's rare for a child to die. As you go down the income gradient, it becomes commonplace. And then we can use case studies in Cuba, which is a very poor country relative to the US, but has the same excellent statistics on infant mortality. We then compare that to Peru, where we actually travel and see a country which is not that much poorer than Cuba, but has a lot more infant mortality. And then one of the places that starts off our program is Haiti. And we read the book Mountains Beyond Mountains, which focuses on the conditions in Haiti that lead to the reality that a lot of kids die. And so one of the things I try to challenge the class with, and they have mulled over all year long, is, oh, this is interesting, this is intellectually worth talking about, but why does this exist, and what can we do about it? Now, again, slides are great, and as a professor, I've made a lot of them to try to make class have a coherence to them. But if you step back once in a while, and we try to do that with this class, we try to bring home the message that these are aggregate statistics of actual people that we sometimes come into contact with. And if you have the chance to come into contact with them, then statistics take on a whole new salience. I'll give you an example. Ben, you're back there. Ben, say hi. All right, that's our younger son, Ben. It's him right here. That graph I just showed you has always been fun to show, and it's always given me a class to get the kids started off with on global health. I was on sabbatical a year and a half ago, and these are Ben's friends at the orphanage that we work at, and they're all visiting the clinic that I worked in the afternoon. And these are his actual friends. They're all there that day because basically they reached the point of malnutrition. The orphanage didn't have enough money to buy enough nutritious food. And they're in for the consequences, the health consequences of when you have malnutrition. Again, a slide is, if you have the chance to have any human contact, it means a lot more. If you live in the places where I've taken these students, and some of you in this room I know have gone, Alex is here. If you live in this part of the world, the developing world, you basically live 100 years in the past, when infectious diseases killed most people. And all the things that are covered in red are communicable diseases that can be totally prevented if you have the right medicines and public health, or they can be easily treated and cured, or they can be treated on a chronic basis. The only one that we have where we live is lower respiratory infections. So the challenge in global health is to figure out how can we take things that are right here in the Student Health Center in abundance and take them to where they're needed, or even better, how can we help the economic development of these places so they can have it on their own? We're going to take it, we don't have to take it to them. The big ones tonight, I'm just going to breeze through these slides because you have experts on almost all of these issues. The big killers in the world that we all are fairly familiar with: AIDS, tuberculosis, malaria, diarrheal diseases, and childbirth. Just being a woman in a developing country and giving birth puts you at risk. Now, these two patients here, Joseph's on the left, I don't know the woman's name on the right. These are slides that I borrowed from Paul Farmer's presentations. Again, trying to make the material come alive to the patients. These are two patients who have tuberculosis and full-blown AIDS, and they're basically coming to Paul Farmer's clinic in Haiti for hospice care. They're coming to die. And Paul Farmer loves giving these slides. In addition to the slides that show all the aggregate statistics, statistics tend to make people kind of numb. If you show slides like this, those statistics are these people. You treat them with the drugs that we have, and this is them 6 months later. And they're able to take care of their family, and they can, if they don't die, which is great for them, obviously, it's also infinitely better for their family. The kids have a much better chance of making it out of poverty. At the end of the class, we have learned basically that there's a diamond of public health. If you live in an area like the University of Richmond, where you have vaccines and immunizations, you have nutritious food, gosh, the D Hall is overrun with it. Although, I think they're going to talk tonight, we should swap the dessert area for the fruit area. That's a pretty measly fruit area in the back with not very ripe fruit. But, we'll come back to that. The dessert table is out of control. If you have vaccines and immunizations, and you are required, if you come here, you have to show proof that you have a full record of vaccinations. If you have clean water and sanitation, we're going to end the night with two fantastic presentations on clean water. Antibiotics. By the way, one more thing about Ben, he contracted scarlet fever, which is not terribly common here anymore, but it responds really well to antibiotics. But it was like the scariest week of our lives, because scarlet fever is what killed Charles Darwin's daughter. Very common down there, sweeps through orphanages. If they have antibiotics, they're fine. If they don't, it's very serious. Family planning resources, trauma care, and economic opportunities. If you live in a place that has all of these features, statistically, you're going to live into your 80s and you're going to have a relatively good life. That doesn't mean you're not going to have illnesses. That doesn't mean you're going to have episodes where you need attention, but you have a good life. The challenge then is, how do we take what we already have in abundance, not expensive, and get it to where it needs to be? Now, this slide, usually people think, okay, distant places, the ones you mentioned, Haiti, Peru, poor places I haven't been to. Another great part of this class that turned out to be even a bigger importance than I imagined or even anticipated was, and I think this is what I love about the program, it has the funding resources, not just to go to Peru, which is where we went, but there are places right here in the United States. You don't have to leave this country to basically confront developing world conditions. This slide right here shows in these red counties, this is the first time in living memory, especially in American history, in which the women in these counties are going to live less long than their parents. Their longevity has plateaued and now is going back down. We were able to figure out, well, why are these areas that we study about in other countries also here in our country? Diabetes rates, you can kind of see an overlap. Really poor areas have really high diabetes rates. We were able to travel 6 hours to the west early in October to a town called Grundy, which is down here in Buchanan County. It's coal mining, and we're going to end our night on a great presentation on coal mining and what's happening in this area. This area has a suicide rate that's 5 times the Virginia average. It's gorgeous, it's aesthetically beautiful, it has some tourism, but it has developing world conditions. We went down there for a weekend, and we got to work in a clinic. Again, I can show documentaries, I can bring in guest speakers, we can talk about health disparities here in the United States, but there's nothing like spending a weekend working in a clinic for people who are uninsured, don't have basic preventive care, and then we realized that the thing that drives most people to these clinics that you would never know, and I could not have taught, is the dental needs. When your teeth really hurt, you will come out to a clinic. You might put off the preventive care, but when your teeth are so painful you can't sleep, you will come out to one of these clinics. And we spent the bulk of the time in this clinic doing dental work. And the other nice thing, another life lesson that I can say in the classroom, but it's hard to have it resonate, is just being reliable and being professional and showing up in life can give you opportunities. And we showed up, we had Alexa, one of the students in the group, thought it might be fun. I thought it was great to get scrubs to increase solidarity among the group. Well, the scrubs, we wore them for the trip. We didn't realize that they sort of connoted third-year dental school. So we got roped into all kinds of, we weren't doing anything too much, but we were doing stuff that maybe we weren't quite 100% prepared for. But it made for a great experience. We didn't do anything that they didn't tell us not to do. 1 week later, we got on a plane and went down to Peru to work in a village clinic to provide us a contrast with the needs in the developing country versus an area like Appalachia. And this is the village we stayed in for about 4 days. And this is the village public health clinic, not terribly sterile, lots of wild dogs, but this is all they have. And that's the first thing you realize, is that the last thing you want to be is critical. This is all they have. You make do with what you have. We did dental cleanings. We did a lot of extractions, not us, but the Peruvian dentist. We ate guinea pig up here. Again, I can sit in class all day and talk about the distinction between prevention and treatment, but you can spend a morning in the clinic doing treatment, especially with dental needs, and then you can run up the hill and see, oh my God, let's do prevention. Let's actually do fluoride treatments, and in the process, prevent people from needing to have dental treatments in the future. And it's so much more real and it's so much more tangible. This is my last slide, and I'm going to introduce our first speaker, our first student presentation. We had a graduate level course. They worked, one way you can teach people about inequality and oppression is assign 10 papers over the summer they have no right or no choice to resist. And I thought that was a good way to get us off on the right foot about inequality in the world. By the time we started in August, they'd read 10 books, analyzed them, done documentaries, done graduate level work, and by the end of the first semester, now at this point, we have a really tight, cohesive group of people who have been inspired. They inspired mostly each other. They've helped each other. They've studied many late nights. And if you look in the brochure about where they're going next year, there's going to be a diaspora of this program, going off to all the different ends of the earth to actually begin to dig deeper into the issues that we have studied all year. And that's the most gratifying thing, is that we have a rich, tight group of friends that have developed over academics who are going to push each other and hold each other accountable. And I think that's the beauty of the program. So without any further ado, I want to introduce the first presentation tonight. Caitlin Harmon and Ali O'Keefe are going to segue off of the Appalachia part that I mentioned briefly and talk about the importance of primary and preventive care. And they're going to use Cuba as a case study to show that even if you don't have a lot of money, don't have a lot of resources, you can still have tremendously good results if you use them appropriately and you target them well. Caitlin and Ali, come on up.
Dr. Mays. Hi, I'm Ali O'Keefe. My name's Caitlin Harmon. First of all, we'd like to thank all of you for coming on behalf of our class. We'd also especially like to thank Dr. Allred and Dr. Ayers for their support of this program, as well as Dr. Mays and Andy Gurka for their inspiration over the past few months. We're all really excited to share with you all the research been doing over the past 2 semesters. One in 3 children in the United States is obese. This is the first generation that will not outlive their parents. The United States spends more than any other country in the world on healthcare, yet has failed to provide high-quality healthcare for all of its citizens.
All semester, we've sought to reconcile the incredible strength of U.S. doctors, the crazy amount that the U.S. spends on healthcare, with the fact that we're currently one of the most unhealthy nations in the world. In Grundy, Virginia, when we were lucky enough to travel with the SSIR program, people are dying of preventable diseases. Illnesses such as diabetes and obesity are caused partially by genetic factors, but environmental factors play a huge role. In America, we like to wait to go to the hospital until it's way too late. We don't go to the doctor until we're actually having a heart attack, and we don't even touch a vegetable until our cholesterol skyrockets. The people of Grundy have an additional barrier in that their grocery stores are stuffed with candy, cookies, chips, and soda, and their fresh food section pale in comparison. Prevention is the cornerstone of public health policy, yet sadly, America has neglected to realize this fact.
Imagine living in a place where you have to drive or even walk 5 miles to find the nearest grocery store. That's kind of difficult for us living here in Richmond, where we can probably find 5 grocery stores within 5 minutes or so. But unfortunately, for a large number of Americans, this is reality. In these food deserts, as they're often referred to, grocery stores are stocked with fast food and junk food and cholesterol. Even if there is no grocery store, McDonald's is the only option, and it's way more expensive, as you can see, to buy your Big Mac and fries as opposed to your salad with grilled chicken on top. The reality here is that although this may save a family a few dollars in the short run, in the long run, this is adding significantly to our healthcare costs, and it's fostering and promoting this obesity epidemic that we have in this country. Let's take a second to compare the health statistics of the United States and Cuba. In the United States, life expectancy is 78 years. In Cuba, it's 78.3. Child mortality rates in the United States are 7.6 for every 1,000 births. In Cuba, it's only 6.5. Cuba has managed to achieve these statistics while paying, on average per person, only $400 per year. In the United States, on the other hand, we spend about $7,000 per year on healthcare. This is just completely fostering this obesity epidemic, and it is a result of our acute bondage to treatment in this country.
To illustrate the difference between treatment and prevention, let's take the example of brushing our teeth. Most of us, as children, were taught to brush our teeth and floss twice a day. Yet, when we were in Grundy, we met a woman who was 18 years old, younger than almost everyone in this room, who had to have every single one of her teeth pulled because she didn't have access to dental care and she hadn't been taught to brush her teeth. At the age of 18, she lost all of her teeth, as well as any hopes of getting dentures because she couldn't afford them. Preventative care is economically beneficial because it helps reduce costs in the long run. Studies have shown that treatment, such as surgery, costs up to 3 times more than preventative care, such as getting vaccines or buying a toothbrush whenever the blue stuff runs out on your toothbrush. Preventative care is also physically beneficial because it gives you a better baseline health and encourages you to be out of the hospital longer, or forever. Our research seeks to address this fundamental question. How can the United States implement preventative strategies and learn from Cuba's example to increase quality and reduce cost?
This figure shows the relationship between GDP per capita and healthcare expenditures per capita. As you can see, the United States spends more than any other country in the world on healthcare. Cuba, which spends approximately $400 per capita, which would lie just about here, proves or even just shows us that high-quality healthcare does not require a massive investment. Not only that, but Cuba has also managed to have average life expectancies comparable to those that we have in the United States, despite dramatically reduced resources.
By the time the average 5th grader graduates elementary school, he has seen 8,000 murders on television. Yet, aside from the relatively low-impact shift of the beloved Cookie Monster to the Veggie Monster, healthy habits have been pushed from the limelight. This chart shows that actual cause of death in the United States varies sharply from what the media portrays. Cerebrovascular diseases and heart diseases are again caused by a lack of attention to prevention, so not eating your Cheerios, pretty much. Murder, on the other hand, as you can see, is a pretty small cause of death. However, treatment is not the only factor causing strife in the U.S. healthcare system. In the wake of World War II, employers scrambled to provide benefits for their employees, which resulted in our U.S. globally unique employer-driven health insurance system. Because health insurance in the U.S. is provided by employers, it's very unreliable. As you can imagine, when you lose your job, you usually only have a few months, and then you also lose your health insurance. Partially to address this unreliability, in the 1960s, the government enacted Medicare and Medicaid. However, Medicare and Medicaid have actually contributed to increased costs. Let me show you why. If I'm a Medicaid beneficiary and I go to the hospital because I've broken my arm, the government will pay the hospital a little bit of compensation to pay for my treatment, but they won't cover the whole cost of my services and doctor time and all that stuff. In order to reach economic equilibrium, the hospital is forced to make other surgeries paid for by private insurance cost more. So basically, some surgeries don't get paid for enough, so others have to pay for a lot in order to reach a nice little happy medium. This is called cost shifting, and it helps spiral our healthcare costs in the U.S. Again, to address this spiraling, in the 1990s, managed care kind of broke out onto the scene. Managed care, or HMOs as they're usually called, are basically one PCP, or primary care provider, through which an individual has access to a whole network of doctors, hospitals, and specialists. However, you can only get to these doctors if you go through your primary care physician, which, as you can imagine, leads to a lot of red tape, it's pretty inconvenient, and you also have reduced choice because you can only go to the doctors in your network. HMOs have actually helped to decrease access to preventative care by basically making it more annoying to do so.
The Cuban healthcare system, on the other hand, hinges on accessibility and universality, and operates under the assumption that healthcare is a fundamental human right for all of its citizens. Because the country has dramatically fewer resources, they've been forced to adopt a more self-reliant and efficient approach to healthcare. They've done so by positively reinforcing preventative measures, such as going to regular doctor visits and just getting outside and playing soccer or having gym at school.
We should take a page out of the Cubans' book and learn that preventative care and healthcare doesn't just happen inside a hospital. We encourage you to think outside the waiting room. Preventative care can be as easy as going for a walk with a friend instead of meeting for coffee. It's also easy enough to pressure your community leaders to make sure that your kids have gym class in their schools.
Developmental economist Amartya Sen once said that political freedoms can help prevent major social disasters, such as widespread famine, because the existence of free, uncensored media draws attention to social needs and allows government policies to be evaluated openly. It is clear that the United States has a perfect political atmosphere to implement successful health policy. We have a very active civil society, and the government is incredibly responsive to citizen demands. Although we recognize that Cuba's system operates under a communist form of government, we do believe as well that the United States policymakers and citizens can learn a few very valuable lessons from Cuba. The first lesson begins with prevention, taking the initiative to seek out preventative measures. Like I said, going to the doctor, playing soccer, just getting outside, and just getting some fresh air even. There is a gap between what health policy can do for you and what it cannot. And that gap can be satisfied through a greater regard for personal responsibility for health. By taking responsibility, we will help our entire system to become more efficient. Our health is in our own hands, so we need to take the initiative, like Cuba has, to do so.
Washington's answer to the U.S. broken healthcare system is the new healthcare bill. Although this bill has caused a lot of controversy in the past few weeks, as I'm sure you're all too well aware, the silver lining lies in that this bill has encouraged preventative care in a way that no U.S. health reform has in the past. It provides $15 billion to target funds that target obesity, and even provides grants to small businesses to create wellness programs for their employees. It also forces fast food restaurants to post their nutritional information in visible spots, and even hopes to close the Part D gap, the Medicare Part D gap, by 2020. This will give more people access to the life-saving antibiotics that Dr. Mays referenced earlier. It also provides higher pay for primary care physicians, which will hopefully encourage more people to seek out preventative care. However, it's not just suits in Washington. It's your responsibility to take care of your own health and that of your family. So go to the doctor every year, make sure you brush your teeth. In fact, just to show you how easy it is, how many people have wasted more than 20 minutes today on Facebook? I have. Yeah, okay. So how about, instead of wasting time on Facebook, if you just go exercise for 20 minutes, eat your spinach, and then you'll be good to go. This isn't exactly how easy it is, but it's definitely a good first step in maintaining our health care. If we all work together to emphasize personal responsibility and prevention, we can have a system that's as efficient, effective, and prevention-driven as Cuba's. Thank you.
Okay, next we have Caitlin Manick and Caitlin Marcoya, who are going to give a presentation on sort of the forgotten stepchild in the larger public health world, which is mental health. And I don't want to steal any of their thunder, so I'm going to let them give you the results of their research. But as someone who's worked in mental health in the United States, it's somewhat within the medical sphere, but it's always given the last amount of resources and often the last amount of prestige, with a lot of devastating results. We're always tempted when we give presentations to try to sort of put in an optimistic, feel-good kind of element to it, and I respect what they've done, which is, based on their research, there isn't tremendous amounts to be optimistic about now, so they're going to take a more raise awareness approach. Caitlin, thank you.
As we begin, we would like you to ask yourselves what illness you think will be the leading cause of death and disability in the world over the next 20 years. What is it that will become the greatest disease of our time?
Perhaps thoughts of AIDS, TB, or malaria come to mind. Those diseases are often in the public eye, so one of them has to top the list.
But those guesses would actually be wrong. It is mental illness that will soon become the most devastating contributor to death and disability around the world. Infectious diseases have been the immediate focus of many aid efforts, but mental illness deserves and requires the same attention. More than AIDS, more than TB, it is mental illness that will come to represent the greatest burden of disease.
The burden of mental illness is felt everywhere.
However, mental illness is particularly troublesome in developing countries, which lack sufficient resources for diagnosis and treatment.
If people aren't mentally fit enough to contribute to their society, a country can't flourish. It can't ascend from poverty, and development will slow.
At the same time, a life of poverty makes a person more likely to develop a mental illness. Thus, a vicious cycle is created.
Children born into poverty and to mothers with poor mental health fall into this cycle.
It is a cycle filled with isolation and misunderstandings that lead to violations of human rights.
1 in 4 people will suffer from a mental illness in their lifetime. 1 in 4 people in this room. 1 in 4 people in each of your lives.
As you think that over, we now have a presentation, Mental Health in the Developing World. The devastating impact of poor mental health can no longer be overlooked.
la santé mentale n'a
Mental
jamais
health
été pris au-
has never been a priority for the Department of Public Health.
Pour le ministère de la Santé publique, nous avons la
We have the will and the
compétence,
competency, however we lack the means.
les moyens. Parce que notre priorité,
The
c'est
patients are our priority, patients with no means. These are the very difficult conditions we're in.
Extrêmement difficile. Nous n'avons
We have absolutely nothing here at the psychiatric center to care for our patients.
de nos malades. Et ensuite,
Then if we write a prescription, the parents are unable to purchase the medication.
les médicaments. Donc, si on doit les hospitaliser,
If we have to keep them, we have beds without mattresses.
on a des lits sans matelas, des cellules pour les malades.
We have cells for patients that are agitated, very aggressive. We put them there to protect them and to calm them down. Afterwards, we take them out, but it's under very difficult conditions.
Vraiment difficile.
Classmates won't allow me to sit with them. They will not lend me any of their things. They won't share their food with me. And as much as possible, they avoid any contact with me.
Next, another topic that's obviously very near and dear to many people in this room's hearts because we've all benefited from good maternal care. Alexa Gruber, Alex Regan, and Inayat Wazir are going to give us a presentation on maternal health abroad and here and show the contrast and the great progress that's been made over the many decades. Thank you very much.
Okay, so when we decided to do maternal health care, we decided to do it from two aspects. We wanted to focus on the developing world while also relating it back to a lot of us in the room and focusing on America as well. And when we were focusing on the developing world, we decided that to really get an in-depth look about a lot of the complications that these women experience in a lot of these nations, we decided to do a case study on obstetric fistulas. The equivalent of 5 jumbo jets worth of women die in childbirth every day. And when you calculate that, it's about 1,500 women every single day dying in childbirth. And almost all of these deaths occur in developing countries. In sub-Saharan Africa, it's actually the region in the world with the worst maternal mortality rates. And it's the only region in the world that has seen little improvement over the last decade. And when you compare that last statistic to a woman in America, she's a 1 in 4,000 chance of dying in childbirth. From these two statistics, it's clear that there's a huge discrepancy in maternal health care between developing and developed countries. And in fact, it's the biggest gap among all health indicators. So this graph is from the World Health Organization, and if you look at sub-Saharan Africa and Southeast Asia, compared to a lot of the more developed countries, especially in the Northern Hemisphere, you can see that there's a huge gap in maternal mortality rates. And if we focus in on Sierra Leone and Western Africa, it actually is the highest maternal mortality rate with 2,100 deaths per 100,000 live births. And that statistic doesn't take into account that women in developing countries, on average, give birth to more children during their lifetime than women in developed countries. So why do women die in childbirth? From this graph, we can see that severe bleeding, infections, eclampsia, and obstructed labor are some of the causes of maternal mortality. While these might be complications in more developed countries like the U.S., because there's inadequate health care in a lot of these developing countries, it results in death. And if we look at indirect causes, which is the gray square, that is accounts for 20% of death, and those are such things as malaria, anemia, and HIV, which are all treatable diseases. But because there's no health care in a lot of these areas, people can't get treated for it. So what are some contributing factors? Lack of rural health care. Most maternal deaths and complications occur in rural villages. One reason for this is because there's a lack of funding and lack of access to adequate health care. There's also a lack of healthcare workers in a lot of these regions. One reason is because a lot of healthcare workers don't want to stay in these rural regions because there's very little funding. So a lot of the time they'll move to the capital of these developing nations. Also, even if you have these healthcare workers in these villages, there's studies shown that only 39% of the time they'll show up to work. And last year, 45 million women had undelivered, had unassisted deliveries. So lack of schooling. A study showed that further education of women would lead to lower maternal mortality rates. Some reasons for this is they would begin childbearing at an older age. On average, their salary would increase, so they'd be able to afford medical care. They'd be more likely to know when they need to seek medical care, and because women are getting educated, it would provide more healthcare workers in these rural regions. For every 1,000 girls who get one additional year of education, 2 fewer women will die in childbirth. So why care about this issue? Maternal mortality is one of the most overlooked and preventable health issues in the world. If this issue was addressed, nearly 500,000 deaths annually could be prevented. And when you're thinking about maternal mortality, you have to think about the children that they leave behind. 20% of the burden of disease in young children is related to poor maternal health care. So that's because a lot of women aren't able to receive prenatal care, and that's from complications during delivery. And many children are also left motherless. Children are 10 times more likely to die within 2 years of their mother's death.
Okay, so as Alex has just demonstrated to all of us, it's really difficult for a lot of women in developing countries to get access to prenatal or maternal health care. And millions of women around the world are suffering from complications or even dying of pregnancy-related causes. So one of these conditions that we wanted to focus in on is called an obstetric fistula. And before I start, I just want to get a show of hands. How many people in this room have ever known someone personally who has suffered from an obstetric fistula? Okay, none. How many people, besides those in the SSIR Global Health class, have ever heard of an obstetric fistula before? Only a couple. Okay, so we'll come back to that. But we wanted to focus on the obstetric fistula. The three of us did a lot of research last semester on obstetric fistulas, and we think it really serves as a bridge to tie the two together. So let me explain a little bit about the obstetric fistula. For a number of reasons, which I'll get into in the next few slides, women in certain developing countries tend to have smaller pelvic canals. So that makes the baby's head a little bit too big to pass through the birth canal, right through the pelvic bone. And then, so that, as you can imagine, that puts a lot of pressure on the pelvic bone itself, as well as the tissues right here and right here, separating the uterus from the bladder or from the rectum. And that's all this inflammation you can see in the red. And then over time, as that pressure continues to build, small holes will actually form between the uterus and the bladder, or between the uterus and the rectum, which we call fistulas. So this would be a fistula, and this would be a rectal fistula. So if you think about it, a gaping hole between your uterus and your bladder would cause an uncontrollable leak of urine through your vagina. And then, in the case of the rectal fistula, it would be an uncontrollable flow of feces through your vagina. So just to put it in perspective, imagine if you lived every day of your life uncontrollably leaking urine down your legs. Well, for 2 million women around the world, that's life. As you can see in these slides, the women over here, there's just a puddle of urine everywhere they go. These women have to be hooked up to catheters just to control the flow. So why is it that 2 million women are suffering from obstetric fistulas today, and hardly anyone in this class had ever heard of one before? For one reason, girls in a lot of developing countries typically marry earlier, and that's also a factor of forced marriage. I've heard of girls as young as 10 years old, even younger, being forced into marriages. And also, this is typically true, not completely true, but typically girls in developing countries get pregnant at an earlier age. And I can just say, when we were in Peru, there were a number of girls who were much younger than us, who were pregnant or had already delivered children and had to stop school because of that. And then also, in a lot of developing countries, women are typically forced to do more manual labor. In these pictures you can see, in a lot of African countries, women are expected to carry water from their villages and back to and from. And then over the years, that really adds up. So here's a little chart you can see. This is a woman of Western descent, a woman of African descent who has been born from years and years of women, generations of women who have also been carrying water, and it really takes a toll on their bodies. Typically, it gives them smaller, shorter frames and a smaller pelvic and birth canal. So that, in conjunction with also getting married at earlier ages, getting pregnant at earlier ages, that's what's perpetuating the obstetric fistula problem. So, fact, it costs only $300 to repair, for the corrective surgery to repair an obstetric fistula. Here are some other things that $300 can buy. An Xbox 360, an iPod Touch, and these Chanel earrings. So it just kind of puts it in perspective for you. Another fact, the obstetric fistula, like we demonstrated before, has essentially been eliminated in the United States due to the high availability of corrective surgery, prenatal care, and just treatments in general, but it's still extremely prevalent in the developing world. So, why are millions of women facing the burden and pain of an easily treatable and preventable obstetric fistula? And more importantly, why is the world standing by and watching?
Okay, so why does this matter to any of us? We live in a country where women don't die of obstetric fistulas, where girls aren't married at ages as young as 8 or 10 years old, and where girls aren't forced to carry water and skip school. It matters because maternal health care is a human right, and even in the United States, women aren't guaranteed that right, and they die every day because of pregnancy-related complications. Before we go into the problems within the U.S. healthcare regarding maternity care, there are advantages that we need to recognize that American women have over women in the developing world. For example, prenatal care and vitamins are widely available, which can help ensure a safe delivery and pregnancy. Also, in the United States, we have the latest technology and medical equipment to help ensure that the delivery is safe and that the pregnancy is safe in terms of, for example, amniocentesis, C-sections, and ultrasounds. For people who are insured, there's easily accessible care in terms of prenatal, postpartum, and during labor. And required education for women means that women will typically wait later to have children, meaning that their bodies are more developed and ready for the trauma of childbirth. It also means that they will have a higher paying job which they can pay and help support for them, hopefully support themselves. On top of education, women typically give birth to fewer children, which means than their counterparts in the developing world, which can be attributed to contraception, birth control, and family planning services that are available in the United States. However, although maternal health in the U.S. is far superior to the developing world, there are still many issues. Women are still dying of pregnancy-related complications. In the United States, we spend more than any other country in the world on maternal health care, about $86 billion a year. Despite of this, we don't see the results, because women in 40 other countries are less likely to die of a pregnancy-related complications. To put this in perspective for you, a woman is 5 times greater to die in the United States than in Greece, 4 times greater to die than in Germany, and 3 times greater to die than in Spain. More than 2 women die in the U.S. every day because of pregnancy-related causes. And near miss, which occurs when a woman almost dies because of pregnancy, has increased by 25% over a 7-year period from 1998 to 2005. What's more disturbing about these figures is the fact that there is no federal law that requires doctors and hospitals to report pregnancy-related complications and deaths, meaning that the CDC estimates that these figures are probably about twice as high. So what's causing this crisis? First of all, lack of insurance. 13 million women in the United States of reproductive age from ages 15 to 44 are uninsured, which means that they can't afford prenatal care. Furthermore, Medicaid eligibility levels for working parents are too low. So if you can't get insurance from your job, if you can't afford to pay for it for yourself, and if you don't qualify for Medicaid, you don't have access to prenatal care. Furthermore, lack of access to some healthcare centers and providers for parts of the population. Georgia ranks 50th in the country for maternal health care, and 44% of Georgian women do not have access to prenatal care. And if you don't have access to prenatal care, you are 3 to 4 times more likely to die of pregnancy-related complications. Furthermore, there's huge racial and geographic disparities within the United States regarding maternal health care. African American women are 4 times more likely to die than a white woman during pregnancy. This map shows the maternal health care ratios, deaths per 100,000 live births. Maine is ranked first in maternal health care in the United States, and it has 1.2 deaths per 100,000 live births. Again, Georgia's ranked 50th, and it has 20.5 deaths per 100,000 live births. But this compares the statistics in our nation capital, which is 34.9 deaths per 100,000 live births. Now, despite that, even in our nation's capital, there's this huge discrepancy between how many women die. It is still a major issue. There are being changes being made, though. In terms of the new healthcare reform, it will increase insurance coverage, which means more women will be able to afford prenatal care, and improve maternal health care and access to contraception for women under Medicaid. So Medicaid eligibility levels will expand, meaning more people can get insurance. Women can stay under their parents' plans until the age of 27 It also improves the system of measuring and reporting maternal health outcomes. And as we talked about before, any improvement is a big improvement since there is no system of measuring and reporting. However, it does leave out undocumented immigrants, which means that the racial discrepancies will probably increase. It also increases further funding for abstinence-only educational programs when there needs to be more family planning services. However, and despite the fact that Washington, D.C. is the worst place in the world for a pregnant woman, they're still very biased. Okay, so how do we tie these two disparities together? How do we connect women like us, like all the women in this room, who are American, who live in a developed country, who have all the prenatal and maternal resources they could ever need? How do we compare ourselves to women in developing countries who are dying every day of easily treatable and preventable complications due to pregnancy-related causes? We thought this quote was a good way to bridge the two together. Maternal deaths in developing countries are often the ultimate tragic outcome of the cumulative denial of women's human rights. So it's an issue of maternal health care being a human right.
Inay's sister, who was in a previous Peru trip, worked in the Obama White House. Not saying there's any connection. But to add to that, Inay's sister, Yasmin, played a leading role in one of our previous trips, fundraising for an ambulance for the town that we visited in Peru to transport women in childbirth. And so far, 2 women have been saved from dying by using the ambulance. Their children were not saved, but their lives were saved. We're going to continue on in women's health. We have Fran Del Rosario and Maria Sebastian, who are going to give a talk on sexual health policies in India and Thailand.
Tonight we're going to present a comparative case study of the sexual health education policies of both India and Thailand. So why India, why Thailand, and why a sexual health education policy? Our interest in this topic stems from both our academic and our personal backgrounds. As for myself, I'm from the Philippines, and in this country there's a very strong sexual presence. To share a little anecdote, last summer, my friends and I decided to rent out a beach house in the Philippines. And as part of this vacation, we had all decided that we would all have massages on the beach because we thought there would be nothing more relaxing than a massage on the beach. When we called the massage place, one of the first questions they asked us was whether we wanted a good-looking massage therapist or a not-so-good-looking one. And when I first heard this question, it made absolutely no sense to me because I thought it didn't matter. But then later, my friend explained to me that there were special sexual connotations attached to having a good-looking massage therapist as opposed to a not-so-good-looking one. Now, I share this story to show that in certain countries, there's just a strong sexual presence that's just reality. However, one of the greatest ironies, and in my opinion is a tragedy, is that the strong sexual presence is not matched by an equally strong presence of contraception use. And in Dr. Mace's class, we learned that Thailand had spearheaded a campaign in which they sought to promote more openness and more visibility with contraception. And I wanted to see if the same mechanisms of the program could be incorporated in the Philippines.
And although I have not had a similar beach house experience, I can say that I have had the great opportunity to visit my family in India every other year since I was born. And while I have lived there for several months at a time, I can't say that I've ever actually been exposed to prostitution or the HIV epidemic, both of which are very prevalent in India. So this project was a really cool opportunity to understand more about the problems that India faces in terms of high-risk groups facing the HIV epidemic and the population at large in their dealings with the HIV epidemic. And as Fran was saying earlier, our decision to research this topic really does date back to well before this class even started. And for me, that's because of my personal interest in women's rights issues and women's empowerment. So again, this project is a really cool way to incorporate my personal heritage as an Indian and also my academic interest in women's rights issues in the developing world.
Okay, so obviously not everyone is from India, not everyone is from the Philippines, and not everyone is from Thailand. So how does this relate to you guys? Sex is one of our most basic, one of our most primal instincts. Maslow, under his hierarchy of needs, categorized sex on the same level and of the same importance as breathing, sleeping, and eating.
And while it may be very intuitive to think that when you do have sex, or if you have sex with another person, it's a very linear process with you on one end and your partner on the other. But through our research of sexually transmitted diseases like HIV, we've actually learned that it's much more complicated, and it almost resembles a very complex web of millions and millions of people who are actually connected through their sexual relations. And this is mainly because what we found is that when you have sex with another person, you're not just sharing your sexual history with your partner, it's almost like saying you're having sex with every other person your partner has sex with, and that's the main issue when we're dealing with sexually transmitted diseases. That makes it even more complicated and even more dangerous to the population in general. And so that's what makes this project especially relevant. And I know that many of us in this room cannot personally identify with prostitutes or injecting drug users or any of the other high-risk groups that are typically mentioned when we're dealing with HIV. But what is important to stress is that we are all connected through our sexual relations with other people because of this very intricate web that involves millions and millions of people, and that just facilitates the spread of STDs, including HIV. So what our project will aim to do is highlight some of the most successful sexual health education programs in India and Thailand. We're going to look at what specifically makes these projects successful, and in the end we're going to conclude with some of the major lessons that we can draw from India and Thailand's experience in combating HIV.
Now, the way we chose to share our research with you guys is through what we like to call a video collage, in which we have compiled a bunch of clips and a bunch of videos while we were doing our project. And by doing this, we hoped that you guys would get a chance to see what we saw as we were doing our research.
Currently, 2.5 million people live with HIV in India. The epidemic first occurred among high-risk populations and is gradually spreading to the general population. These high-risk groups include commercial sex workers and truck drivers. Although a major outbreak has not yet occurred among the general population, governments and NGOs must take preventive measures to avoid this potential disaster. In the absence of strong government-led initiatives, the important mission of educating Indians of safe sexual behavior now rests with NGOs. The most successful NGO project in India is the Sonagachi Peer Education Project, designated a best practice model by UNAIDS. Sonagachi is the largest red light district in Calcutta, home to an estimated 10,000 commercial sex workers. In 1992, Smarajit Jana, a public health scientist, initiated a peer education project among female sex workers in Sonagachi. He followed the general principles of peer education by teaching safe sexual behavior to female sex workers, who would then teach the same lesson to other sex workers. Because Jana sought to empower ordinary female prostitutes who were most at risk, he helped establish a collective called the Durbar Mahila Samanwaya Committee as part of the Sonagachi Project. This coalition of sex workers would help their peers with daily challenges like disputes with customers or landladies. Although Jana helped design the coalition, sex workers themselves now spearhead the DMSC. The collective organizes women into a strong political constituency by demanding full workers' rights and vocational programs. It also assists impoverished sex workers by distributing microcredit loans. The Sonagachi Project successfully increased condom use from 27% in 1992 to 86% in 2001. The project continues to have an impact as seen in the decrease in HIV prevalence from 11% in 2001 to 4% in 2004. The project strongly benefited from its ability to actively involve community members in project design and implementation. The leadership of women in the DMSC not only provides a strong political voice to sex workers, but also a sense of empowerment. Another NGO program is the Saheli Project in Mumbai. It is also a peer education program that trains sex workers. By utilizing a pyramid structure of brothel managers and sex workers, the project reached over 5,500 female sex workers in Mumbai. This project also offered an additional salary to sex worker participants, earning between $3 and $30 a month for teaching fellow sex workers. These participants also receive an ID card to receive store discounts at places like their local vegetable markets. The Saheli Project also reduced HIV prevalence and increased condom use in areas of Mumbai. For instance, in 1991, less than 5% of Saheli sex workers used condoms with their clients. In 2003, however, over 95% of the Saheli sex workers used condoms. Government-led programs are not using the same successful techniques. Instead, it has focused its efforts on public school education programs and awareness campaigns for at-risk groups. But these may soon end since more and more Indian states have banned public sexual health education because it is not considered appropriate. India is now at a crossroads. It can either continue its removal of necessary preventive measures, or it can wake up to the dark reality of a steadily rising HIV prevalence. India must follow Thailand's lead in promoting open discussion of HIV through government-led initiatives.
Thailand's HIV/AIDS program under Anand Panayarchun's administration is hailed by UNAIDS as one of the 3 best practices in the world, the other 2 being Uganda and Senegal. Thailand's experience with HIV/AIDS highlights the importance of a strong national leader, in this case, Prime Minister Anand Panayarchun. In 1989, Thailand's HIV/AIDS statistics look bleak. In the northern town of Chiang Mai alone, 44% of sex workers were found to be infected with HIV. As this explosive epidemic surfaced, a new leader came to power. On March 2, 1991, Anand Panayarchun was sworn in as the Prime Minister of Thailand.
In our own times, we face compelling questions.
He enacted a significant structural change. He moved the National AIDS Prevention and Control Committee from the Ministry of Public Health to the Office of Prime Minister, thus increasing its political influence and its budget, which increased almost 20-fold to $44 million in 1993. Following the widespread sentiment that sex work would dominate the Thai epidemic, efforts were concentrated towards the sex industry. By mid-1992, the 100% condom program was implemented in all provinces throughout Thailand. The
The mechanics of the program were simple, requiring all establishments and sex workers to use condoms in every sex act. Routine checkups were conducted, and an STD positive result could be used as an indicator of ongoing risk behavior and failing to use condoms consistently. This violation of the 100% condom program could lead to the closing of the establishment, which many owners feared. One reason the 100% condom program was successful was its national implementation. National implementation ensured that all 76 of Thailand's provinces enforced this rule. It ensured that a man could not just go to another brothel in another province which did not follow the no condom, no sex policy. Another important factor in the program's success was the use of Thailand's pre-existing public health infrastructure. A national program becomes ineffective without the infrastructure to carry it forward. The main directive is issued out from the Prime Minister to the Ministry of Public Health. Then, although the Ministry of Public Health spearheads the program, responsibilities for program management are divided between two government bodies: the Regional Offices of Communicable Disease Control, the RCDCs, and Provincial Public Health Offices, PPHOs. Both branches are responsible for numerous public health initiatives, which included the 100% condom program once it was implemented. The national government also implemented a mass media campaign which mandated Thailand's 488 radio stations to play one anti-AIDS message every hour. The visibility of the condom in Thailand has also grown, thanks to Nichai Viravadia, former Minister of Tourism and the founder of the nonprofit organization Population and Development Association, or as he is known in Thailand, the Condom King.
Nichai Viravadia has tirelessly campaigned for AIDS prevention, handing out thousands of condoms trying to destigmatize them. Such has been its success that in Thailand, condoms are simply known as Nichais. Nichai's restaurant Cabbages.
Nichai has opened several restaurants in Thailand called Cabbages and Condoms, which aims to make the condom as common as the cabbage, which is found in many Thai dishes. Nichai has also held several Miss Condom pageants, thereby making condoms more accepted and more accessible.
This sign says Thailand's HIV infection rate has been slashed from 143,000 cases in 1991 to just 21,000 in 2003.
However, the initial success of the 1990s AIDS campaign has died down, and the landscape is shifting. According to UNESCO Bangkok, at present an estimated 1 in 100 adults are infected with HIV, and AIDS has become a leading cause of death in Thailand. What makes a sexual health education program successful? Whether run by governments or nonprofits, whether in India or in Thailand, certain features contributed to the success of a sexual health education program. For instance, in India, NGO programs have been more successful than government education programs in reducing HIV prevalence and increasing condom use. The most effective NGO program, the Sonagachi Project, was successful because it empowered ordinary female sex workers through the establishment of a workers' collective. Another NGO initiative, the Saheli Project, also empowered women through peer education and offered an additional salary. In Thailand, the 100% condom program was successful because it was a national initiative from the Prime Minister emerging from the top down. Also contributing to its success was the pre-existing health infrastructure, which enabled the delivery of the 100% condom program to be more effective. Thailand's mass media campaign was effective because it reached the broadest audience possible, broadcasting anti-AIDS messages once every hour. In addition to strong government initiative, the presence of a passionate advocate for safe sex, Nichai Viravadia played an instrumental role in destigmatizing condom use. He was the effective because he organized light and fun activities like Miss Condom pageants and Cups and Rubbers programs, where he distributed condoms to the entire Bangkok police force. However, one of the most important aspects of Thailand's sexual health education campaign was its national leadership, which India has long been lacking and which has declined in Thailand since Anand Pinayarachan's administration, causing a resurgence in HIV and AIDS rates.